Good evening. I would like to welcome you all here, both in Calvin's Chapel and also for those of you that are watching us online tonight. My name is Terry Crum. I am the pre-health advisor here at Calvin University. We are welcomed here by many pre-health students that have been allowed to gather in the chapel for this lecture. And for those of you that are online, we hope you enjoy this lecture. The Your Health Lecture Series is a unique educational partnership between Michigan State University College of Medicine, Spectrum Health, and Calvin University. The goal of this series is to feature speakers, MDs, PhDs, MD PhDs, who can speak on a wide variety of topics of interest to public audiences. Tonight, we would like to welcome you to the lecture series entitled The Hidden Epidemic, Human Trafficking. And we are very fortunate to have 3 speakers from the Grand Rapids area. Directly behind me is Nikeidra Battle-DeBarge. She is the Manasseh Project Coordinator, which is affiliated with Wedgwood Christian Services, and she is the Executive Director of New Destinies Pathways. The Manasseh Project of Wedgwood Christian Services is an outreach ministry dedicated to ending the sexual exploitation of young women and men in West Michigan. New Destinies Pathways provides affordable and supportive independent living housing to young women ages 17 to 21, aging out of the foster care system. Nikeidra received her degree in criminal justice and corrections from Ferris State University. To my left here is Andrea Rocafort. She is a hospital supervisor at Helen DeVos Children's Hospital and an adjunct clinical instructor for Grand Valley State University. She has worked as a registered nurse in the emergency and trauma care for over 10 years and has had encounters with unique patient situations that sparked her interest in the issues of human trafficking, especially the commercial sexual exploitation of children. Andrea is a member of the Kent County Human Trafficking Task Force, and in 2018, she took a leadership position as the medical chair on the task force. She received her bachelor's and master's degree in nursing from Davenport University. And finally, here to my right is Dr. Lisa Lowery. She is a physician of adolescent medicine at Spectrum Health and Helen DeVos Children's Hospital, and she is also an associate professor at Michigan State University's College of Human Medicine. Lisa was recently named the College of Human Medicine's Assistant Dean for Diversity and Cultural Initiatives just in April of 2020. She earned her Bachelor of Science degree in microbiology from MSU and her medical degree from the University of Michigan. She completed a combined internal medicine and pediatric residency at Spectrum Health in Grand Rapids, and later a fellowship in adolescent medicine at Johns Hopkins University, where she obtained her master's in public health degree. We're going to start off tonight's lecture with Nikeidra.
Good evening, and thank you for having me. Again, my name is Nikeidra Battle-DeBarge, and I'm excited to be here. And we have a small amount of time, so you're probably going to feel like you're taking a drink out of Niagara Falls in such a small time with all this information. As stated before, the Manasseh Project is an outreach of Wedgwood Christian Services, and our goal is to provide awareness, education, advocacy, and treatment. A couple of the objectives that we'll talk about today is the epidemic hidden in plain sight, debunking myths about human trafficking, risk factors, potential victims, and how to identify potential victims, and how local organizations and healthcare professionals are responding to the crisis. Now I'm just going to hit on a couple of myths. There are lots and lots out there, but I'm going to hit on a couple of them just because these are some of the most prominent ones, but you can imagine that there are lots when it comes to human trafficking. The ones that we hear often is that Michigan is number 2 in the United States for human trafficking. Like, I know we like to be popular, however, we don't know that that's the truth. There is no data that says that Michigan is number 2. Unfortunately, it will be difficult even if we did have the data to say for sure how many people, because a lot of the individuals who have been victimized do not self-identify, as well as a lot of them are not connected to a system, so they don't necessarily know that that person is a victim. Oh, do I sound muffled? Hello? Hey, can you hear me better? Oh, I'm sorry. So, do you want me to start over? Or could you hear me well? Okay. And then the other thing with Michigan being number 2 is that you may have someone who is trafficked in Michigan, and then they're also trafficked in Ohio. So then do you count them multiple times? So this is a complex issue, and we don't have numbers. And what I always tell people is, if it's happening to one, that's too many. The other one is that it's the man in the white van, or a Meijer or Target. A lot of times when we hear about someone that's being trafficked, it's not necessarily someone being forced into it or snatched. Is that part of it? Yes, that would be considered guerrilla pimping, where someone is forced into the industry, they're snatched, they're taken by force. But what we see most often in the United States is someone developing a relationship, getting to know that person, maybe online. They may meet them at Meijer or Target. However, having someone being snatched at a public place like Meijer or Walmart or Target would be a lot more difficult than to develop a relationship with that person. So I'm not saying it doesn't happen, but I am saying it's more likely that it will be a more Romeo pimping type of scenario where they're developing a relationship, pretending to be their boyfriend or girlfriend, providing them with gifts, and making them feel comfortable. Traffickers always target victims they don't know. That's another myth. A lot of times the trafficked victim is connected in some way to this person, whether it's a family friend, a boyfriend, so a romantic partner, girlfriend, or someone, like I said, that they've met in a situation online or in person somewhere else. But the myth is that it's always someone being forced into it through being someone that they don't know. Trafficking involves moving, traveling, or transporting a person across state or national borders. A lot of times, trafficking can happen anywhere. You can live in your own home and be trafficked. So the myth that it only happens with someone snatching you or taking you from another country is not necessarily the case. Does that happen? Absolutely. But what we see most often is it usually happens within the state that that person lives. So let's talk about what human trafficking is. Human trafficking is, and this is kind of a, it's as brief as we can make it, but it's such a complex issue. Human trafficking is the business of stealing freedom, profit. In some cases, traffickers trick, defraud, or physically force victims into selling sex. In others, victims are lied to, assaulted, threatened, or manipulated into working under inhumane, illegal, or otherwise unacceptable conditions. So human trafficking is the big issue. And then we have labor trafficking and sex trafficking. So labor trafficking is the crime of using force, fraud, or coercion to induce another individual to work or to provide service. And then sex trafficking is pretty much the same, except it's typically using fraud or coercion to induce another individual to perform commercial sex. We see labor trafficking a lot in the food industry, hair salon, nail salon, groceries, grocery departments or stores, the hotel industry. Anywhere that there's a service being provided, there could be someone being trafficked. Action, means, and purpose. So a minor who is induced into commercial sex is considered human trafficking no matter their age. If they're under the age of 18, they don't have to prove force, fraud, or coercion. For an adult, you have to have force, fraud, or coercion in place in order for that person to be considered a human trafficking victim. When I say force, I mean someone who snatches them into the industry, forces them into the industry physically or aggressively. More of the coercion is, if you don't do this, then I'll do that. And then you also have fraud, where they're telling them that they're coming for one reason and they're actually coming for another. We talked about grooming. Romeo pimping is more of controlling their victims through psychological manipulation. They may work with other family friends to help convince the victim that they are trustworthy. And I want to stay here for a second just to say that a victim doesn't have to be a female. Males are also victimized, and a trafficker doesn't have to be a male. So a lot of times that's a myth as well, that it's only girls or that it's only men that are that are trafficking. And then the gorilla pimping, when we think about gorilla pimping, we think more about the movie Taken, that idea where they're forcing them or snatching them. I usually like to use that as an example. Most people have seen that movie. Certain populations are especially more vulnerable. Runaway and homeless youth is said to be the #1 entry into this industry. We can imagine why. If you have nothing and someone offers you something, you're probably going to take the better deal. Previous sexual abuse, the statistics have said previously that 85 to 90% of those who have been trafficked have been sexually abused. And in our program, about 100% of those who have been trafficked have been sexually abused. Poverty. So when we talk about poverty, we immediately think about financial poverty. The other part of that is emotional poverty. So sometimes it's not just the financial piece, but it's the emotional piece. When you're looking for someone to love you, someone to tell you these great things about you, someone to fulfill you emotionally, and then this person comes along and tells you everything that you want to hear. Transient male population. We think of truck drivers, conventioneers, people who are coming in and out of different places. Existing commercial sex industries like massage parlors, strip clubs, phone sex operators. Familial trafficking, for me as a mother, is probably one of the most difficult things to understand, the fact that there are families or parents who will traffic their children for something that they perceive as valuable. Drugs, alcohol, rent money. Substance abuse is very complex in this issue. When you think about someone who may provide drugs for a victim so that they will continue to come back to them to get that fix, to get high or to whatever that is for them. They know that they can't afford it on their own, so they'll provide it for them so that they can lower their inhibitions, so that they can work longer hours, and so they can make more money off of them. The other part of that is that they may give them the drugs to hold, to say, if we get pulled over by the police and you tell, you're going to go to jail as well. And sometimes the victims want to be on drugs because they don't want to deal with the actual things that are happening to them. Mental health concerns. A lot of times individuals with mental health concerns are targeted because they can't make certain decisions or they're easily manipulated. So parents of the youth, and I speak a lot about youth because I work in a youth agency, but you can imagine that adults who were once kids who are in this situation as well. And then foster care or residential, going from house to house, not necessarily having the stability and looking for that place and looking for that fitting. So anyone who has ever been to any of my presentations know that I love this because it just tells the background of the person that is being victimized. Typically, for years, we've looked at prostitution as a victimless crime, and what this does is kind of helps us understand that it's not a victimless crime, and that typically someone is vulnerable to something, and that's why they will get into a situation like this or pulled into a situation. What happens to them, and I'm going to quickly go through this because I'm going to be short on time, but the violation of boundaries. So typically, we talked about child sexual abuse being one of those vulnerabilities of someone who's being trafficked. What happens to them is that their boundaries are violated. They don't know who they can trust, so they don't necessarily tell anybody. They feel guilty and ashamed, so they internalize it, and then they become the bad person. They view themselves as a sexual object, so they don't see their identity outside of that. Their self-esteem is beaten up. Typically, especially when we're talking about adolescents, this is the age where they're learning about themselves. They're trying to get to know themselves. There's lots going on at home and lots going on in their environment. So this is the time where they're trying to build their self-esteem, and a lot of times traffickers know this. We talked about runaway or homeless youth, poverty, unequal power dynamics between adult and child relationship. We're told as children to respect adults, to trust adults, and the problem is that traffickers use that to their advantage. Media influence can take all night, but I won't, especially now during the pandemic where people have so much access to the internet and so much access to technology. They become even more vulnerable during times like this. Schools are out and they're home, parents are at work. So technology is huge, and the media has a huge influence because that's what they're watching all the time. That's what they're listening to all the time. This is what they see, and so they model after what they see. If someone is not teaching them a difference, or trying to, and sometimes even when you try to teach them a difference, that sometimes can be louder than what's being taught in the home. Demand, it's $1 billion industry, and that's one of the things that we definitely need to address, is that if we decrease the demand or remove the demand, we don't need a product if we don't have someone buying. So we have to definitely address that in order to see changes being made. So we have to talk more about the John. We talk a lot about the trafficker, but the John gets a slap on his or her hand, and they move on. So in order to decrease this issue, we have to address demand. So then after all those things have happened, you can imagine that by that time, they have been groomed for industry like human trafficking. A couple of signs. Maybe the age of the individual has been verified to be under the age of 18. So that would be, like I said before, if you're under the age of 18 and you have been identified as a victim, no force, fraud, or coercion is necessary. Visible signs of abuse, so marks, black eyes, burns, fear and anxiety, depression, submission, tension, hypervigilance or paranoia, express interest in older relationships, evidence of controlling or dominating relationships, unexplained access to money or possessions. I always tell parents, if your kid if you don't know where they got it from, they don't have a job, you need to be asking questions. And that's, for a family's period. Not in control of their own money, use of lingo like the life or daddy, secrecy about whereabouts, unaccounted for time, and they're defensive when you ask them about their time. Tattoos are marks that he or she is reluctant to explain. Keeping late or unusual hours, wearing clothes that is unsuitable for the weather. Personal information such as age, name, and or date of birth may change, or information given may contradict itself. And sometimes, and I'm sure that this will be talked about, but sometimes even when you are going through screening, you may not remember something. So you may have a situation because of the trauma, you may not remember certain things. However, a lot of times it will contradict itself. The information will contradict itself. Has no identification, has an explicitly sexual online profile, homeless or runaway, like we talked before, truancy or tardiness from home or school, and family dysfunction, to name a few. We can go on and on about some of the vulnerabilities or risk factors, but this is what we have seen, and this is what we know are more prevalent. That is my time. Thank you so much for having me, and we will move on to... Yep.
All right, thank you. All right, thank you, Nikeidra. As we learned from her what human trafficking is and different types of labor and sex, I'm going to talk about how it affects the healthcare. What do we see in the healthcare setting, and kind of what are the signs that increase your suspicion and what the response would be? So what we do know is there's a very few validated screening tools, because you think, well, shouldn't we know if this person is trafficked? Can't we just ask them some basic questions and find out? A lot of times our victims, our patient victims, don't realize that they're trafficked. They don't know what trafficked means, or they think it's not me because he loves me. So really, it's a lot harder to screen for somebody who has been trafficked. So we really need to get more research on it, more statistical data, and evidence-based research. But as we know, it takes a lot of time for evidence-based research. And who wants to sign up for a research study on being trafficked? Who wants to answer the survey questions? Or who's going to say, I have been trafficked? We also don't have a great standard care of education. You hear our presentation today. But you could go listen to a presentation that's done in California, you could listen to a presentation that's done in Georgia, and you're going to hear different things that have different statistical information or how to respond. So it is the things that still need to be worked on and recognized throughout our healthcare. And then the biggest one is utilizing more of trauma-informed care. And I'm hoping that through education of both medical and nursing is that you are getting more of an understanding of the trauma-informed care, as we are seeing that more and more people have been abused, and it affects how their behaviors and their vulnerabilities are. And it really is a public health concern, and not having that judgment for our patients when we're caring for them. So the frontline response. As I said, it is a public health care issue for many reasons. One thing that any trafficking victim has in common is a loss of freedom. They might have that loss of freedom. They can't go out. They have to clean. They're not allowed to hang out with friends. They're like the Cinderella story, maybe a servant to their parents. Or it could be that they have nowhere to stay, and the only time they can have a roof over their head is if they are providing sexual acts for somebody else. No matter what it is, somebody who's trafficked has lost their freedom. It may look different for any patient that you might see, but the one common thing is that loss of freedom. Also, as I said, they don't really realize that they're trafficked. They aren't going to come in and say, this is what's going on with me. They're going to come in for any chief complaint that could be for UTI, sexually transmitted diseases, possibly pregnancy, or vomiting. Whatever it might be, it could look like any other type of patient. And so this is where we need to start coming up with some tools and to help us really see and identify some of those trafficking victims. And we really do have that unique opportunity to provide some care and understanding for that patient. The annual health laws did say that 88% through their survey, 88% of people surveyed these were sex trafficking survivors, stated that they did visit a health care type of facility, either urgent care, a primary care, or an ER during their time of being trafficked. That is quite significant, and healthcare really has a position to maybe be there and provide a space of trust to help them maybe feel that comfort that they can say, hey, something is wrong, something's not right, I don't know what to do, I'm not safe, in different types of words for them. So what you could see is, Nikeidra had kind of talked about it too, is they might have inconsistent stories, or it could be very scripted. So they're coming into the facility and they say that I fell down the stairs. However, their injuries do not look like they fell down the stairs. And they have some bruising that they cannot explain. They might not be able to tell you where they were last night. And so those are things that we want to look at and try to understand. And it makes it difficult because there is so many different types of forms of abuse on how to differentiate sometimes between them. And that's where a healthcare team can actually work together on identifying it. So you also could see if they are with somebody who's more dominant or a friend who's answering all the questions. So if you say, hey, can you tell me about that tattoo? And they're very hesitant to tell you about that tattoo, and the friend's like, it's not a big deal. We're here because they're not feeling good. Can we just get something to make her stop vomiting and we go home? Like, they can be very dominant in not letting the patient actually do the talking. So that is one thing that we do have to try to do, is create that relationship to have that conversation to get them to trust us. They can avoid contact, they can appear afraid or overly submissive or very anxious. Now, they can switch on you on a dime because they, if you think about it, have maybe lived on the streets or know how to protect themselves from very bad situations. One of the situations that a provider had told me about is that he was able to get the female out of the room because she wasn't answering any of his questions, and he really wanted to ask, and the person that was with her would not leave, so he went in and he's like, hey, I need to use the otoscope, but my light's not working. Let's go pop into the other exam room. And so he was able to kind of get her out of the room to ask these questions, and she became actually very defensive based on his approach, and he noticed it afterwards. So we really do have to pay attention to our approach too. We cannot just come out and say, is he hurting you? Do you feel safe? We need to have them kind of trust us and say, is everything okay? Is there anything you want to talk about? These are things that maybe will help open them up to have that trusting relationship. And I cannot say that enough, that really we want to empower them to kind of recognize some of that and trust us as that healthcare provider. So the red flags or presentation things that could be warning signs for you is that they could come in with multiple sexual partners. They could say, yeah, how many partners have you had? I've had about 30. And you say, okay, well, 30 and how much of a time? So looking at what are they talking about? Do they have multiple urinary tract infections that are maybe not getting taken care of, or they're not finishing their antibiotic? You're looking at the whole picture and asking these questions. They can have an overall lack of health care. So preventative health care for them are pretty much non-existent. So their diabetes might not be controlled. Their hypertension could not be controlled. And then preventative health care as well. So not going in for a PAP or just a regular annual physical is not happening. So those are questions that we kind of want to ask and have these conversations with them. They can have signs of strangulation, but not really fully remember. Yeah, we were fighting, but then we just ended up drinking and I passed out. Well, can you tell me a little bit, what were you guys fighting? Did he put his hands on you? Trying to get more information because maybe they recollect it as I was drunk or I was doing drugs, but he could have choked her or, quote, strangled her. So different things that they might say to get that suspicion up to ask further questions. Inappropriate clothing as well, and then the tattoos. Most people who have tattoos are very willing to have the conversation of what the tattoo is, and that's a good way to kind of build trust with your patient, is say, hey, that's a really cool tattoo. Can you tell me more about it? And just trying to get kind of like break the ice to have that conversation. So, and then your common chief complaints that they could come in, as I've said previously a little bit, is like a depression or STIs, a pregnancy, maybe an abortion that they had done somewhere else, but now having consistent bleeding. Because some of these trafficked victims are having non-qualified doctors providing care for them. So they might have, oh, well, I got this drug, but I don't know what it is, and it's in this bottle, it's not labeled. It's just some of those things that might think that they're getting care that was hired by the trafficker to try to keep them because it's a renewable source for them. They want them healthy enough to provide that income for them. And then overall is, how are you going to respond? So when you start seeing some of these flags, what do you want to do? And that's really hard as a healthcare provider. We're still trying to figure that out. Places are starting to place a guideline on kind of an algorithm. If you do identify some of the red flags, you should reach out to a social worker or to someone else on getting those questions. What kind of resources do they want? Do they want help? Because that's one thing as somebody who's over 18, we need to ask them. We need to empower them if they want that help. Because they might say nothing's wrong, no, I don't get out, but they know their safety best. So if they tell you today, they might be worried that they're not going to live through tomorrow, or their kid might not live through tomorrow. So we have to remember they know their safety best. We want to empower them. And maybe if they don't say something to us, that then when they go into a visit or a follow-up visit, they'll feel safe enough to talk to that provider. So we're really providing that. And then if it's a minor, we are mandated by the law that we do need to report it to CPS. And with that reporting, when you have somebody that you're suspicious of human trafficking along with being a minor, you also have to contact law enforcement, which a lot of people do not realize. So it does need to be a dual thing, so they both can go in there and kind of do an investigation. Another way, too, is if it's an elder or a vulnerable adult, so somebody who's mentally challenged or has disabilities can also be filed through like adult protective services. And then your police reportable cases that are used with deadly weapons or tried to inflict more danger, then you can go ahead and report. However, if it's just some bruises, they're kind of denying it, they don't want any help, we cannot do anything, which is really hard as a healthcare provider because we want to go in and we want to save the day. But we have to remember that we're here to help them provide trust in the resources. You can always provide a human trafficking hotline number, but do please be creative on how you can provide that. Is it a number that they could write in the sole of their shoe? Could it be maybe that they can write it under a different contact in their phone? Because somebody who is controlling them is going to see what resources they might take or find out or look through their phone. So I want you to think about kind of what is it that you would want to know more about. So as you listen to Dr. Lowery and as you continue on through your profession, what can you do to make a difference? What do you need to learn more about? Is it something of what would I do if somebody said, yes, I'm being trafficked, or yes, I'm being hurt? Do you know what to do? I ask you, are you afraid of HIPAA? Would I violate HIPAA if I'm reporting? Is it that I just have to go see other patients and I need to get them through the door? I'm worried about throughput. I don't have time for this. It's somebody else's problem. So I really challenge all of you to really think of what stops you from questioning and being more trauma-informed to help our patients. All right.
Good afternoon, good evening. So thank you, Nikeidra and Andrea. And so I'm actually going to share just a little bit of work that Dr. Megan Lanier, she actually graduated from our residency program this past spring and moved to Milwaukee, moved back home. But her and I, along with Andrea, have been doing a lot of work over the past couple years around sex trafficking and kind of how do we identify and all the, and you can hear me okay? Y'all can hear me okay? So I really wanted to share that and probably also build upon, and you'll hear the things that are kind of repetitive. I'll probably go through pretty quickly so then we can open it up for time and questions. So we're just going to talk about a little bit the human consequences of human trafficking, management of trafficking victims, and cover some of the resources in our Grand Rapids area. There's a wide array, have you heard, of physical and psychological health issues, but preventative care, like we said earlier, is basically non-existent. Treatment is often given at critical points of care, and traffickers will often hire unqualified people to care for victims. Violence, we know there's physical and sexual abuse, there's forced sex, threatening with weapons, being strangled, being beaten, even withholding of food. Zimmerman et al. Reported sex trafficking women, 94%, over 94% had a prevalence of violence. It can be emotional and physical violence. And then Turner, Moss et al., labor trafficked men, a third of them, prevalence of physical abuse. And again, a lot of times when we say sex trafficking or human trafficking, an image pops into our mind, and we rarely think of males, but we also have to remember our males, and especially our refugee population. They're very vulnerable to sex trafficking. When we talk about reproductive health, it is the most common reported health issue because a lot of times they're at risk for having frequent sexual transmitted infections like HIV, gonorrhea, chlamydia, syphilis, pelvic inflammatory disease, unwanted pregnancies, and abortions. And there was a study that showed more than half of sex trafficking victims had had at least one abortion. Physical health, infections like we talked about, dental problems, chronic disease, low back pain, and often you may see these in our practice because they can come in with, these kind of, I think I have a bladder infection, I think I have back pain, and you're seeing them, and that's almost kind of a cry for help, but most of the time we miss it. And there's been studies, like Andrea said, that these victims have been seen by their primary healthcare workers or urgent care and even emergency rooms, and we miss it. Neurologic, headaches, dizziness, malnutrition and eating disorders, anxiety, depression. Over 40% have attempted suicide, and then PTSD. And that is, again, the ongoing problem that we see, especially with our victims. alcohol and substance abuse. Even after they are out of the sex trafficked situation, they may resort to substances and alcohol to numb the pain, a lack of self-worth, and feeling of helplessness, shame, and shock, as you heard. Trauma-coerced bonding, deterioration of oneself. They're dependent on the abuser. And again, that may be why that one victim Andrea mentioned got defensive, because all they've been told is, I'm the only one that can help you. If you lose me or get me arrested, you will be homeless. You won't have any place to live. You'll go to jail. And that's just basically ingrained into them. So, or I see this person as, this is the person that, why would he's not abusing me, or she's not abusing me. Let's get the gender out of it. She's not abusing me. Look at all the things. I got my hair done, my nails done, I have a place to stay. And no self-worth, and maybe the only social support. And like Nikeidra said, especially if they've come from an unstable home life, and this is now, look at now, they found someone that loves them. And unfortunately, their love is, well, if you love me, you'll have sex with this person and that person and that person. Trauma-informed care, and it really is something, and I'll admit, I've been practicing for about 16 years now, and it really is something that has just really become more commonplace over the past few years. And it's really understanding the impact of trafficking on their minds and bodies, understanding the trauma, the bonding experience. So many times, especially as healthcare providers, we want a solution and then we want to fix it. And sometimes by wanting to fix it, we get to good and bad. And sometimes it's not good and bad, but it's this multi-layer. There's these years of abuse and trauma. And again, building that relationship of trust, respect, and non-judgment. And I've had patients that I've seen for years, and then they've told me, 4 or 5 years later, or even when they became an adult. And then again, you want to ensure confidentiality and safety. Training on how to manage and treat victims. So Dr. Lanier and I, we interviewed over 300 Spectrum Health employees, physicians, nurses, social workers, and asked them some simple questions about, like, how comfortable are you managing, seeing someone who has been a sex trafficking victim. 92% were not at all comfortable, or only somewhat comfortable with managing and treating the victim. 66% had never received training. And I didn't take the survey, but before, when I went through residency, we didn't talk about sex trafficking. My training become being an educator of sex trafficking. And 53% do not know what to do if they encounter a human trafficking victim. And a lot of us, if you're in a private practice trying to get through 15 patients, and you don't have a social worker, good luck. So, but I'm just saying, or I'm in the emergency room and I'm backed up. So what am I gonna do? A lot of them, the first answer was, contact the social worker. Okay? We want to have patient-centered care, trying to talk to the patient alone, give back decision-making capacity over their body and control. Do you want to be seen by male or female staff? Are you comfortable with portions of the physical exam? Even navigating getting the patient alone, like Andrea mentioned, can be difficult because, again, and I've actually used that technique to get the patient alone, and it works all the time. Treating diagnosed missed diseases, discuss ways to communicate results of testing, set up follow-up appointments. Oh, I want to see you back for that back pain. Okay, maybe I don't really want to see him back for the back pain, but I'm going to see him back because I have a concern. Is there another number? Sliding the number to us. One of the things we found out when we did the survey, one of the most unique things is people actually then started emailing us and contacting us with ideas and was like, hey, have you thought about giving it on a card, something that can slip in their shoe? Have you thought about this? Andrea and I actually talked about giving information on like chapstick or lip gloss or something like that, because no one's going to think I've given you like health information or a crisis line on like lip balm or something like that. Offer resources, law enforcement. And again, the biggest thing is it's been ingrained into you. If I've told you, if you say something, you're going to go to jail, you're going to go to jail, you're going to go to jail, what are you going to do? Well, I'm not going to say anything because what? I'm going to go to jail. Forensics exams at the YWCA, social work, community-based resources. Respect the patient's decision if they don't want help. Again, that's aligning and developing that rapport, and try to be non-judgmental. I mean, again, you want the patient, you want the adult to seek help, but again, it is their decision. And a lot of times it's just letting them know, I'm going to be here for you. We talked about the ways to get information. Long-term care, I think this is where I've had more experience, just what the repercussions like PTSD, dealing with issues of self-worth, so really involving comprehensive medical care and mental health services, housing services, because, you know, when I was being abused by you, I had a roof over my head. And now, Dr. Lowery, you trying to tell me not to have a roof over my head? So bringing in housing and working with like Network 180 as well as Manasseh and all our resources and Arbor Circle Homeless Youth Program, just a few resources in town. Financial assistance, life skills. Again, a lot of these patients, depending on their age, maybe they're no longer going to school. When's the last, we got to get them re-enrolled. And then again, the other big thing is they don't want you to call the police because I'm going to get deported. And that's another thing. 75% of surveyed victims said they needed a safe space and job training. Here's just a task force line, human trafficking line. There's a couple other resources, this Be Free text line. So again, so some of my patients, even, for example, I may tell them, say if it's a suicide hotline number, put it in as something kooky, you know, like Pizza Hut or, you know, McDonald's. And, you know, no one's going to look at your phone and be like, why you got the Pizza Hut number in your phone or whatever. Or you can always double it up as someone else's name. So you have two names. You have two Mary Janeses in your phone or something like that. And so those are ways to maybe help navigate. And again, here's just Dr. Lanier provided this website, Human Trafficking Website Hub. I'm sure both Nikeidra and Andrea are very familiar with it. If you also want more information, if you go online, there's HEAL, H-E-A-L. Trafficking is a nationwide collaborative. You can get on a listserv and get a lot of information as well. I think the hardest thing, and one of the things pre-COVID we were working on, is how do we develop a screening protocol? And so we worked, Dr. Lanier and Andrea worked very well to develop a screening protocol, because as a busy provider, I just want to know, what do I need to get? Who do I need to call? How do I help the patient? So we developed, in the process of getting the protocol approved, that provides what testing based on age, based on what labs you need to order. And again, we talked about this category, whether it's food, legal, awareness, employment counseling. It is a really multidisciplinary approach. And here are some other resources that we mentioned: Manasseh, Arbor Circle Homeless Youth, Sacred Beginnings, 211. A lot of community resources. The YWCA is also a good resource, their examiner program, and Network 180. So that's our presentation, and I think we have time to turn it over for questions.
So our questions can be directed specifically to the speakers based on their area of where they're working and out in the community. We also are going to field some questions from our Zoom audience, and so we're going to be kind of going back and forth. So I just want to open it up. I would like you guys to ask your question into the mic, if at all possible. We'll start with one from our chat feature.
What is the primary way trafficked individuals are apprehended? Is it usually through stings, visits to the ED?
They're caught. Can you repeat the question?
Yep. What is the primary way trafficked individuals are apprehended? Is it usually through stings or visits to the ED?
There are multiple ways in which an individual should I stand up? There are multiple ways in which individuals can be apprehended through stings. We've had multiple children come through Kids First and come through our program because of a sting that they have annually. Usually they're identified because they're a part of a system. So if they're in foster care, or in a residential system, or in juvenile detention centers, those are usually how they're identified. Or if they've been arrested for something like shoplifting or something of that nature. If they may have gone to the hospital for some type of issue, and then they have been reported based off of that. So there are multiple ways in which they can be identified. Those are the most prevalent ways.
How would you offer the human trafficking hotline to a patient who does not realize that they are a victim of human trafficking?
So the way, when I have concern that you've been trafficked, I'll usually say, I have a concern. You know, you're coming in and, you know, maybe there's a concerning tattoo, or maybe they've had multiple STIs. And I said, you know what, I'm really concerned. I'm really concerned about your safety. And so I probably don't use this word, I'm concerned that you're trafficked, but I'm concerned that you're unsafe. You know, are you in a safe space? I'm concerned about the relationships you're having. One particular incident, we had a young lady who kept running away from home. And so we had to be, you know, at some point, you shouldn't be 14, 15 out on, you know, in the streets in the middle of the night. And then when it's more of an adult patient, it's really like, you know, I'm really concerned that you're in a very unhealthy, unsafe relationship. And that's usually how I start the conversation. And then if they go, well, what do you mean? You know, we might have to go further down.
What are the strategies for empowering individuals who we may encounter who are hesitant to take control of their safety?
To take control.
Okay. Well, I think for empowering our victims, it's going to be a lot through the trauma-informed care and really building that trusting relationship, taking the time with them, and giving an opportunity to talk. So there's a couple of survivors that I've spoke to that have said that they have felt more abused by healthcare than their actual abusers. And that was because of, we sit there and we fill out our charting, or we kind of come in and stand over them. So kind of that empowerment and trusting is sitting next to the bedside and ask, are you okay? Because yes, we do have to ask the safety questions. Do you feel safe? Is anybody hurting you? Those type of requirement questions. But we really need to take it to a step further if we have those concerns and saying, is everything going okay at home? How's school going? Or just trying to find a little bit of way, because that gives them empowerment to have that trust in you and start talking about it. And then really kind of trying to provide those resources, but giving them that option. Like, is there something I can do for you? What is the most helpful? As Dr. Lowery said, in community resources, what do you need? What are you concerned about? Are you concerned about housing? Are you concerned about food? Like looking for those areas, and I think that will help.
What are some of the specific challenges sex trafficking survivors are facing during the COVID-19 pandemic, either in the medical setting or outside in the community?
So I think I will say, I don't think we're capturing people, because no one's, people weren't coming in. So there was 2 or 3 months we said, don't come in to the hospital, don't come into your doctor's office. So I know, especially from an educational standpoint, a lot of educators are really concerned that, you know, these young people are at home and I'm not seeing them. So I think that's probably the most significant challenge that we saw that we're not seeing people. And the other thing I think is, I would say our focus was not on that. My focus might have been on something else. So I think that's probably the challenge, is that people were kind of stagnant. I'll let you.
With not having access to people, having access to food, some of those things those daily needs, and so then they're going to look for that, and they're going to be targeted because they're known to not have these things, and like I said, the access to technology, being able to be accessible to a trafficker. Not like Dr. Lowery said, not being able to lay eyes on an individual who's being abused or neglected. So they're being faced with lots of different challenges, especially with things being closed and not having the supportive resources that are necessary to keep them safe.
I have a question. If you were out, it's one thing if you're in a medical setting, but if you're out in the community, let's say in an airport or a bus terminal, train terminal, somewhere out in the public, or even at the mall, and a child or a young teen approached you, and you had some immediate concerns of what they came to you about, and what would you do? You know what I mean? You're in a public, would you just put them in your car and take them somewhere? What would be your suggestion if just in normal walks of life? I mean, again, it's one thing to be approached in a healthcare setting. You've got social workers, you've got resources, you've got teams around you. But if you're in a public setting, which many of us are, what would you suggest that we do as community members to support that person and to not turn them away or bring them to a scary situation, you know what I mean, where they might be more afraid? I'm just curious what your suggestions might be.
I would say first start off by being kind. I know that seems like this big thing, but kindness goes a long way. That person feels like they can trust you. They can stay they can go back to their perpetrator, and they know how they're going to treat them. When they're in the community, they're expecting for somebody to go to bat for them and to show them respect and not make them feel belittled by that person. So that starts with that. So being open to have the communication with them, make them feel safe that they're even, because it takes a lot for somebody to come to you, especially a stranger, to say, hey, I'm in a bad situation. I always see, I have a different kind of personality, so I'm one of those people that might try to take you in the car with me. I've had situations like that. However, as I'm learning more, I have to keep myself safe as well. So I would definitely call the police right there where I stand, or if you're at a store and there's a security guard, alert the security guard, let them know what's going on, and have them call the police. Maybe even stay there with them until the police arrive. And kind of some of the other things is to make sure, maybe if you have a card or something, or if you know the trafficking number, you can write it down for them or something. But typically, if they're in that area, their trafficker is probably watching. I had a scenario where a young person, I was a foster care case manager, and she was at the grocery store, and I came to give her some money, and she was looking kind of like downtrodden. I asked her, was she okay? And she said yes. And then she said, no, he's watching me, I'll call you later. So at that moment, my natural instinct was to take her with me, but I also knew if he's watching her, he's watching me, so I have to be careful. So you can't put on this red cape and go, take someone into safety without thinking about how you putting yourself at risk as well. So I would definitely alert the police and kind of try to stay there with them if possible.
I'm going to say there's a lot of great questions online, and there's no way we're going to get to all of them. So I'm going to try my best to kind of combine some of these. As the mom of a trafficking survivor, there's a long-term healing journey. What is the best way to navigate all the resources? Is there a case management resource?
How to navigate that? So, the first thing is I would basically make sure the person, let me stand up, I apologize, that I would make sure that the patient is in counseling. I think that's the first and foremost, and make sure their basic needs are met. And then kind of stepwise for their where they are, from an education standpoint and things. I don't think there's kind of like one size fits all approach to helping them long term. It just really is their basic needs. And it sounded like this person was the parent of one. Okay,
I have a couple questions here involving, are you seeing any victims that are involved in gang activity as well?
I'm sorry. Can you repeat that?
Any victims in gang activity?
Of course, yes. And a lot of times, just like with a gang, they're looking for family. They're looking for support. They're looking for people to say that they love them and that they care about what happens to them. So gang activity is a part of this industry as well. So you see a lot of victims who come in with different tattoos that identifies them as someone who has been a part of a gang.
I assume homeless LGBT youth are especially vulnerable. What resources are available for them?
Pretty much similar resources. I think you want to make sure that the provider that they're working with is LGBTQ friendly. I think that's the biggest thing because, like Andrea said, they can be re-victimized again. Same resources, and actually some of especially our LGBTQ as well as our transgender patients, they're even more at risk for being sex trafficked. There's some data that shows that as well. Community resources that I use, depending on, again, this is a person that is kind of post-traffic, so they're out of the situation, and we're helping them kind of get back in. If they need resources like Arbor Circle Homeless Youth, as well as HQ in Grand Rapids is a great resource. So those are just a couple community resources that I know are LGBTQ friendly as well.
And again, I'm going to try to combine a couple of these, and this might be helpful for some of the undergraduate students in the room as well. A lot of questions about how can doctors or nurses be trained better in medical school or nursing school, maybe build it into the curriculum. Is this possible? As a nursing student, what is the most effective way that I can combat human trafficking? Is this through educating myself or identifying those that might be trafficked, or something else entirely?
That's a big question. So, yes, I think it's starting to be built more into curriculum as you do cover some domestic violence and child abuse in schooling. Human trafficking should be in there as well. So I have talked to a few nursing students that have said that they have received it, but I've also talked to some who have not. So it is going to come. It might take a while before it gets into textbooks, and it needs to be there. And what I think for you as a student, if you haven't received the information, the best thing is to first educate yourself, because to really understand or identify human trafficking, I think you need to educate yourself, and looking at different things that you could see for warning signs, or understanding the vulnerabilities along with trauma-informed care, or also ACEs is a really good study to learn and understand as well, which is the childhood events or experiences. And that's really good as well, to kind of understand some of things that put them into the vulnerabilities. So that would be my first and foremost thing, is to kind of educate yourself. And that's how I actually got started, is I took care of a almost positive victim. Nobody else believed me. They all thought I was crazy because that didn't happen here in West Michigan. And so this was 8+ years ago, and I decided, okay, well, I need to educate myself so I can educate others and reach out to other survivors to hear their side of the story.
And just like Black Dr. Lanier, she actually took just not the data we use, but developed and put it into a curriculum for our residents. I think the one thing we have to work on is sustainability. And then I'm working with another medical student who, well, actually now she's an intern, who developed a curriculum for medical students, and we're trying to, again, keep it going, so it's just not a one and done.
And I will say that teachers are doing a phenomenal job more now than before. I think I have 5 interviews this week with students who are in the medical field and are looking to do projects around human trafficking. And I actually go several times a year to multiple colleges and universities. So I'm actually thankful that this has become more of a conversation and that teachers are taking the initiative to educate their kids, even if it's outside of the curriculum.
Mm-hmm.
All right, we have time for one more question. There's like 20 on the chat feature, but we wanted to open it up for any students. Do you guys have any other questions? Anybody? Otherwise, we'll just go ahead and pick one more out of the...
Let's see. So many. You've been talking about tattoos. What specifically are we looking for?
Honestly, it could be anything. One of the survivors that I spoke to had love loyalty on her arm. And I mean, really, it's not anything that's suspicious, but it was like, hey, what does that mean? Can you tell me about it? And that is actually the trafficker had that tattooed on all of his victims, so he could go, and if they tried to run or if they tried to leave, then somebody else, such as, like if you think of a gang, would be like, nope, sorry, you belong to him. So those are different ways they kind of, quote, tag their victims, and it's a way to identify who belongs to who. So really there is no set thing. You do hear of like barcodes or something else, but it can be anything that is meaning to the trafficker or a way to identify that person. So really that's why asking those questions of like, hey, can you tell me more about that? What does that mean to you? Why did you get that? Those are the things that is really kind of helpful to identify.
All right, how about a round of applause for our speakers tonight? Thank you so much for everybody that was able to join us. The session is being recorded. It's going to be on Michigan State's site. So if you have other people in your practice, other coworkers, other community members, other students that are going to want to take part in this, please follow that recording. You can go right to the Your Health Lecture Series through MSU and find information. All right, thank you and have a great evening. For the students that are here, can you guys just stay, if you can, stay just a quick second? So I'm assuming we're off the recording at this point. But we presented this information to you guys, but we realized